Welcome everyone. My name is Chrissy Nicholson. My pronouns are she and her, and I'm the Manager of Gender Equality and Capability at Women's Health in the South East, otherwise known as WHISE. Welcome to the My Body and My Voice report launch. We are so excited to have you all here today, but also to launch this very important report. It's a really groundbreaking report that highlights the stories of women with disabilities and their relationship to their bodies, their voices that are often not heard and bodies that are often not represented in this space. And this report, one of the first reports of its kind, seeks to ensure that the voices of women with disabilities are heard, that their bodies are recognised, and that we can have some really amazing recommendations for health practitioners and primary prevention practitioners to ensure these voices are heard and to ensure that women with disabilities and their bodies have the respect and equity that they deserve. As I mentioned earlier, we'll be recording this webinar today. It will go for about an hour and a half, and there'll be a 5-minute break in between. Before I start the formal proceedings, I'd like to start by acknowledging the traditional owners of the lands in which we all come from today. I'm coming to you from the lands of the Bunurong people, and I'd like to pay my respects to elders past, present and emerging, and to any Aboriginal people and First Nations people here today. If you are able to, we'd love to see who is in the room today, and please feel free to put in the chat your name, which country you come from in regards to the First Nations country you come from, and also if you come from an organisation, which organisation you're from. Today, you can see some support services up there. Talking about body image can be confronting. So if this raises any issues for you, please reach out to the support services recommended here today. There's the National Helpline, Butterfly Foundation Helpline, and Eating Disorders Victoria. And of course, in an emergency, please always reach out to 000. I want to also acknowledge the support of Butterfly Foundation and Women with Disabilities today in regards to the technical support they're able to provide to this report. And to tell you a little bit about who WHISE is, we are one of 12 women's health services across Victoria, and we have 4 different priority areas that we work on: gender equality, the prevention of violence against women, improving sexual and reproductive health, and improving women's health and wellbeing. The agenda today, we're going to go through a little bit about the introduction and background, and that will be our wonderful Natalie Opasinis, who is from our Women's Health in the South East organisation, and she's been the spearhead and leader of this project. Then we have Dr. Rachel Bush, also from WHISE, who will be talking about the project methodology and some of the key recommendations. We'll then have a break and then come back into our panel discussions. We're very excited to have Jessie Hooper, who is a lived experience disability advocate, and Joe Money from Eat, Love and Live, joining Natalie for our panel presentation. Now, the report. There is so many pieces to this report. It's a massive report and so much work has gone into it. It's over 80 pages long, including annexes. Don't let that scare you. It really, really captures the lived experience of women with disabilities. It's got lots of incredible quotes, recommendations. Please use this, this QR code to download the report. It'll also be on our website, and there should be a link in the chat for you as well. There's also, to make it a bit easier for those who don't want to get into all the details but want a snapshot, there's several resources that come along with this, which includes an executive summary and some report recommendations, which are 2 to 3 pages. So it has something for everyone. Next slide, please. All right, so without further ado, I'm going to hand over to Nat, who is going to lead us in a short exercise. Thank you, Nat.
Hi, everyone. I'm Nat. So when you hear or see the phrase body image, what is it that comes to your mind? What is it that you feel in your body? Or are there any sensations that come into your body? Or is it that you see a text in your mind? If you feel safe and comfortable enough to do so, you're welcome to share what comes up for you in the chat.
Okay, I'm not
Okay.
sure. We've been told that the chat's been disabled, so I'm just wondering if it's possible to turn the chat on. There's always a few tech issues to start with, aren't there? So bear with us. As we turn the chat on.
Apologies, everybody. I think I've now enabled everybody to be able to chat.
Oh, there we go. That's
Thanks,
better. Thanks, Rach. I will also reshare a few things before I move on. So here is the report link to everyone. Follow that link if you'd like to see the full version of the report. And of course, I also, if you need support at all during the webinar, please do contact any of these support services. Okay.
Thank you. And if you are able to then now introduce yourselves and the land you come from, that would be fantastic. Also, a note to let you know that if you need closed captions, there is a section at the bottom of the Zoom call that you can enable those captions. Go ahead, Nat, and thanks for bearing with us with our technical issues.
Yes, body image is complicated and messy. I agree. I'm coming to you from Wurundjeri land. Okay. So thank you, everyone. I also find body image very complicated, nuanced, and messy. Even if it's just a body sensation that comes up, I often feel a bit tense when the phrase body image is mentioned. Outward appearance and its alignment with social expectations. Thank you, Malavika. Yeah, misunderstood, powerful, often dismissed. Absolutely. Thank you so much. Body image often describes how one thinks about, feels toward, treats, and experiences being inside their own body. Happy, yeah, never good enough. Yeah, it's a tough one. Maltreatment, stigma, and discrimination negatively impact one's body image, whilst simultaneously creating a societal ideal body type in which we are encouraged to compare ourselves and aspire toward in order to alleviate said maltreatment, stigma, and discrimination. In this way, particularly women are burdened 3 times over. First, with the societal gender inequity. Second, with the individual responsibility to overcome these inequities by changing their bodies to fit the ideal. Third, with the shame and blame of not being able to reach an impossible ideal body or overcome the inequity. And so naturally, negative body image ensues. Thanks. Next slide. Thanks, Rich. Thanks to everyone who's joining in on the chat. Much appreciated. So, research shows that women with negative body image are at increased risk of anxiety, depression, low self-esteem, eating disorder development, social isolation, difficulty maintaining relationships, reduced economic participation, and increased risk of developing chronic diseases. Just to name a few, that's not even all of them. However, there is little research investigating body image in women with intersecting identities, such as women with disabilities and women from culturally and racially marginalized groups. Women with disabilities and intersecting identities face multiple forms of marginalization, including ableism, sexism, and racism, which amplifies the stigma and discrimination their bodies endure throughout their lives. Despite this, academic research, healthcare practices, and national conversations about body image have ignored the experiences of women with disabilities and intersecting identities, instead focusing solely on the able-bodied. The My Body, My Voice project set out to diversify the body image discourse by taking a gendered, intersectional approach to understanding body image and its socio-cultural influences in women with disabilities and intersecting identities. The project explored the intersection of ableism and sexism, along with influences of culture in an Anglo-Australian context. We set out to close the health equity gap by creating a platform for further research and community initiatives that will better meet the body image and health needs of all women. Thanks, Rach. Our project set out to answer the following 4 research questions. How do women with disabilities and other intersecting identities think about, feel toward, and treat their bodies? What are the drivers of negative body image of women with disabilities and other intersecting identities? Are there any protective body image factors for women with disabilities and other intersecting identities? And if so, what are they? Are the body image concerns of women with disabilities and other intersecting identities addressed appropriately and effectively by health and medical professionals? What have been their experiences? Are the current health promotion strategies to promote healthy body image, such as body positivity, body gratitude, and body neutrality, appropriate and effective at addressing the body image concerns of women with disabilities and intersecting identities? If not, what would be? I'll now introduce you to our Evidence and Policy Lead, Dr. Rachel Bush, who will step you through the methods we took to answer these research questions. Over to you, Rach.
Thanks, Nat. Hello to everyone joining us online today. I'm coming to you from the Wurundjeri lands, very overcast and cool today. I can't see any of you, but I'm thrilled to have you here, and I'm especially delighted to be sharing some of the findings from My Body, My Voice. Before I do, I'm going to start by giving a bit of an outline of the methods for this study, so you know what we did, before telling you about who participated and then what was found. So the My Body, My Voice study consisted of 2 components. We had a community survey and focus groups. The survey aimed to understand the experiences of women with disabilities regarding body image, body dissatisfaction, and their interactions with the health system. We promoted the survey through a number of channels, and we were particularly grateful to Women with Disabilities Victoria and Butterfly Foundation for their invaluable support in promoting the survey and providing technical advice on the survey questions as well as the report. Participants had multiple options for completing the survey, including online submissions through SurveyMonkey, completing it in Microsoft Word, printed copies, or over the phone with assistance. We were thrilled to see a remarkable response, with 94 people accessing the survey within only 1 month, which for any of you joining us today who has tried to get responses to a community survey, you'll understand just how incredible that response rate is and really reflects how desperately this topic needed to be explored. So the eligibility criteria included identifying as a woman or being assigned female at birth, being aged 18 to 65, and having a current or previous disability. So after filtering out anyone who didn't meet the criteria, we ended up with 73 eligible participants, which was absolutely amazing. Following the survey, we conducted focus groups, inviting participants who expressed interest at the end of the survey, provided they lived within WHISE's Southern Metropolitan Region of Melbourne, and each participant received a $50 gift card as a token of appreciation for their time. We held the focus groups on Zoom, and they lasted about 90 minutes, although I believe they often ran over due to the rich conversations that the participants were having with our facilitators. And we hosted 2 focus groups. We had 2 women attend each session. We had hoped for more participants and more focus groups, but To be honest, the complexity of their daily lives for these participants, attending a focus group at the very end of the day is quite a big ask. And this was something that was shared in the survey findings, that for some women with disabilities, they may commit to appointments or social engagements in advance, but face difficulties attending due to health, energy, and capacity issues. And this isn't always, but sometimes. And so we were very understanding, of course, and our priority was the participants' health and well-being. And we had already heard so much rich information and experiences in the survey. I want to take a moment to describe the group of participants, because it's really important that you understand who you're hearing from before I share what they told us. The majority of participants, 94%, identified as women, 5% identified as non-binary, and one person identified as a trans woman. The age distribution, as you can see, was varied, with the majority aged between 25 and 44 years. Many of the participants were Anglo-Australian, a few were from European or Asian backgrounds, and 5 of the participants identified as Aboriginal or Torres Strait Islander. Participants were asked if they had a permanent or temporary disability, and the majority shared that they had a permanent disability, and these were diverse in range. I've included some of the broader categories of these on the slide, and I welcome you to read the report, which includes a much more exhaustive list. So I'm going to share some key themes which emerged from the survey and focus groups. Now, due to time limitations, I unfortunately can't speak to everything that we found. So I do urge you to read the report, as there were so many rich findings. So we're going to first discuss the relationship between body image and self-perception. Participants talked about having a complex relationship with their body, which was often influenced by societal expectations and personal struggles. And this shouldn't be surprising, because the perception or really judgment of others and uninvited feedback impacts the way we all perceive ourselves. But for women with disabilities, we found this to be heightened because they don't physically match the ideal person portrayed in the media that women are told they should look like. And for many participants, being unable to fit within the social aesthetic standard and challenging the social norms has led to feelings of inadequacy. And some impactful quotes are on the slide, where participants considered what body image meant to them. Participants reported experiencing constant expectations to conform to ideals of beauty, health, and ability. Often the pressures were based on aesthetics, being pressured to conform to a beauty standard that's unattainable and having a body that isn't celebrated in the media. In fact, many participants felt and were often told by healthcare professionals or family that they had to lose weight or attain a shape that matched the social ideal, despite the limitations posed by their disability. And so participants often reflected on the difficulties they experienced controlling their weight. And this went hand in hand with discussion around difficulties controlling the functionality of their body. And because the headlining message was often to lose weight with no tailored advice on how they could safely do this, or whether this was right for them due to their medical history, it meant some participants would adopt unhealthy and dangerous practices, such as restricting their food intake or foregoing important medication which caused weight gain, in order to regain some control and strive to meet beauty standards. The lack of representation of disabled bodies in the media only exacerbates these feelings, leaving many women with disabilities, or at least the women in our study, to feel marginalised and excluded from broader narratives of beauty and wellness. Societal pressures weren't always aesthetic though. They extended to functional expectations as well, with participants feeling compelled to perform tasks or behave in certain ways that are associated with being able-bodied. And this could sometimes lead to feelings of frustration and inadequacy. For example, keeping a social engagement despite chronic fatigue or chronic pain so as not to appear unreliable, or pushing themselves at work to keep up with their colleagues. These behaviours were self-described as being harmful and detrimental to their function and health, and further negatively impacted their relationship with their body. Participants reported feeling disconnected from their bodies, especially when experiencing chronic pain. And this disconnection or disembodiment often served as a coping mechanism to manage physical pain and frustration. And some participants experienced a disconnect between their lived experience and the medical perspective. For example, being told that they need to lose weight when they didn't necessarily feel this way when they looked in the mirror, or having their lived experiences of chronic pain dismissed, or being told that their disability or their chronic pain is due to their weight. Such negative interactions resulted in disempowerment and further disconnection from their bodies. Some participants even stopped seeking medical care altogether, which really highlights how profoundly these experiences can impact overall well-being. Another key theme that came up was around identity. Some participants expressed a struggle of balancing their identities as women and as individuals with disabilities. And in fact, they experienced erasure of their identity as a woman altogether, as their disabilities overshadowed other aspects of who they are. And so usually our gender is our primary marker of identity. It's what people notice first and shapes those initial impressions and assumptions about us. For women with disabilities, it's often their disability that becomes a primary marker of identity, particularly in their interactions with the health system. And so the gendered expression of womanhood and biological sex-driven needs, wants, desires are dismissed as non-existent. And so this ongoing rejection of the presence of a gendered and sexual identity can be incredibly harmful to a person's body image. Some participants reported pressure to conform to traditional standards of appearance and behaviour, touching on the concept of performing femininity by dressing in a particular way and wearing makeup and doing things to appear feminine so as not to be perceived as being less of a woman in society's eyes. But sometimes the reality of living with a disability would clash with gendered expectations. And I think this is so strongly demonstrated in the last quote on the slide, where the participant discusses the ways in which she felt she doesn't fit societal expectations around femininity, such as stimming, not making eye contact, having skin sores, bloating. The last prevalent theme I'm going to discuss relates to the loss of control that many participants experienced and spoke about. Many described feeling powerless over their bodies due to limitations imposed by their disabilities. This lack of control often resulted in frustration, grief, and a sense of betrayal by their bodies. However, it's really crucial to recognise here that this perceived loss of control stems not just from their disabilities, but also from ableism, which is embedded in society. The absence of structural support, such as ramps, wider doorways, and sensory-friendly environments, combined with the insufficient social support, which significantly hinders participation in daily activities and reinforces feelings of powerlessness and diminished agency. Some participants shared their journeys of adaptation, learning to focus on what their bodies can do rather than what they can't do. Coping mechanisms varied, with some finding solace in body neutrality or body positivity movements, but others felt excluded by these movements that often don't address the unique challenges faced by women with disabilities. So by now, I hope you can see that the experiences of women with disabilities regarding body image and self-perception are deeply complex and influenced by a myriad of factors, including societal norms and healthcare interactions. And as you reflect on these findings, I'm sure it's clear that advocating for better representation, improved healthcare practices, and structural support systems are all essential to foster a more inclusive environment. So now let's turn our attention to some recommendations. I'm only going to present some of the recommendations. Again, due to time limitations, I could talk all day about this project. So again, I invite you to read the full report, or you can take a look at the fact sheets which present the recommendations for both the healthcare system and for primary prevention and early intervention of body dissatisfaction in women with disabilities. These recommendations have been developed using what we heard in the survey and focus groups. The first recommendation is to listen, believe, and respect women with disabilities. Participants discussed often feeling unheard or dismissed due to assumptions based on their physical appearance or disability. And this is likely because the healthcare system views disability primarily as a problem to be fixed, rather than understanding it as a social construct shaped by barriers and attitudes. Yet, by listening to and believing women with disabilities, healthcare professionals can validate their experiences, build trust, and provide more effective care. So we're asking that you pay close attention to the health concerns of women with disabilities and consider their perspectives. Recognize their valuable lived experiences and knowledge about their bodies. Also, respect women with disabilities by acknowledging their humanity and individuality. Avoid making assumptions based on their appearance or disability, and instead understand that their experiences are influenced by a complex interplay of social, environmental, and attitudinal factors. And remember that disability is one aspect of a person's identity, much like, for instance, race, ethnicity, and gender. We also recommend adopting patient-centered care because this embraces an intersectional, trauma-informed, and size-inclusive approach, which may help restore autonomy to women with disabilities. It ensures that their voices are heard, respected, and included in medical and health decisions, leading to a more inclusive healthcare environment. So some key actions to take include delivering holistic, patient-centered care that integrates trauma-informed practice, HAYS principles or health at every size principles, and size-inclusive approaches. We're asking that you prioritise taking an intersectional and inclusive approach to care, acknowledging the diverse experiences of women with disabilities. And to improve your self-awareness of unconscious biases related to gender, appearance, body size, shape or weight, ethnicity and ability, and actively challenge your own medical and health biases on an ongoing basis. We further recommend that healthcare professionals receive training on early prevention and risk factors for body dissatisfaction in women with disabilities. Healthcare professionals need to be able to recognise early warning signs and understand that they can be masked by the complexities of disability. But if properly trained, health providers can offer timely preventative interventions and provide patients with the guidance and support they need before these issues escalate into more severe conditions. And also, as was touched on with the previous recommendation, we'd love to see training that addresses medical bias and weight stigma within healthcare practices to help create a more inclusive environment where women with disabilities are more likely to feel validated and supported rather than judged or dismissed. And to ensure sustainability, healthcare governing bodies should implement ongoing professional development modules that require practitioners to regularly update their knowledge on the latest evidence-based practices for prevention and early intervention in body dissatisfaction and eating disorders, with a focus on how these conditions manifest uniquely in women with disabilities. We also recommend that you advocate for disability inclusivity campaigns in media and public health initiatives, because these types of messaging can have a profound impact on shaping societal attitudes towards body image and beauty standards. When campaigns promoting body image fail to include or accurately represent women with disabilities, they inadvertently reinforce harmful stereotypes. They perpetuate feelings of exclusion and inadequacy among those who do not see themselves reflected in these messages. So let's challenge narrow beauty standards, reduce stigma, and create more inclusive environments that support healthier perceptions of body image for all women. The visibility of diverse bodies, especially those that diverge from the dominant narrative, can play a crucial role in normalizing differences and promoting acceptance. When women with disabilities are visible and valued in media and public health campaigns, they feel seen and empowered. And this visibility can reduce the risk of body dissatisfaction, disordered eating, and associated mental health issues. So we're asking that public health campaigns and media initiatives authentically represent diverse bodies, including women with visible and invisible disabilities, to challenge narrow beauty standards and reduce stigma. And importantly, these campaigns should not only highlight body diversity, but also celebrate the strength, resilience, and varied lived experiences of women with disabilities, steering clear of harmful stereotypes that frame disability as something to overcome. Another recommendation, I've got two more, is to promote increased diversity and representation of women with disabilities, because this is essential for shifting societal perceptions and reducing stigma. When women with disabilities hold visible and influential roles, especially in leadership positions, it fosters greater inclusivity and ensures diverse perspectives are integrated into decision-making processes. This representation is essential as it highlights the unique needs and interests of women with disabilities, shaping more equitable policies and practices. And in the context of healthcare, it creates a far more inclusive environment that better meets the needs of all patients. So to achieve this, we need to increase visibility of women with disabilities in leadership roles and healthcare professions. This approach ensures that care for women with disabilities is informed by their lived experiences and responsive to their specific needs. Implementing a lived experience framework is crucial for safely and ethically embedding these perspectives into organisational practices. So although the framework up on the slide, this one targets gender-based violence, however, it provides a clear pathway on how to ethically embed lived experience perspectives into organisational practices. And I've included a QR code on the slide so you can save the link and check out this incredible resource. It's called Embedding Lived Experience in the Primary Prevention of Gender-Based Violence, and it was developed by Promoting Respect and Equity Together partnership. So please do check it out. And the last recommendation I'll discuss is the need to increase government funding for community-based programs for women with disabilities. Why is this important? Community-based programs designed specifically for women with disabilities can help create a sense of belonging and connection, which are essential protective factors against mental health struggles such as body dissatisfaction. By providing access to supportive, inclusive environments where women with disabilities can engage in meaningful activities, these programs may help protect against the risk of body dissatisfaction and also empower women with disabilities to embrace their identities and strengths. So please advocate for substantial government investment in community-based programs that support women with disabilities across diverse areas of life, including mental and physical health, social inclusion, and personal development. These programs should be fully accessible, affordable, and available in multiple formats, such as in person, online, or hybrid. to accommodate different types of disabilities and living situations. And they must be developed using a co-design approach with women with disabilities to address their specific needs and interests. So I'd recommend using, again, another helpful framework up on the slide here called Australian Framework for the Ethical Co-Production of Research and Evaluation with Victim Survivors of Domestic, Family and Sexual Violence. So again, this framework, it is focused on gender-based violence, but it was developed by lived experience researchers and provides clear steps for ethically co-producing programs and can certainly be applied for developing programs for women with disabilities. So again, there's a QR code. I believe Nat's posting links in the chat for you all. So I again encourage you to take a look at this resource. So that is now all from me. I hope that you will read the report and the fact sheets. And so now I'll pass back over to Chrissy. Thank you all so much for listening.
Thank you so much, Rachel. My goodness, there is so much there, isn't there? And, you know, it was a real struggle for Rach and Nat to decide which recommendations and what to highlight, because what Rach just highlighted was just a few of the several more recommendations in the report. So we do recommend you go there and have a look, and also the powerful quotes and stories that do you know, tell you more about how this data came into to become this report. The one thing that really stood out to me, Rachel, when you were talking, was one phrase, which is about acknowledging humanity. And that's really what it comes down to, looking at the strengths and resilience, and also the lived experience of people with disabilities, particularly women and those gender diverse people. And I just want to remind people that all of these recommendations and all of what you've heard today are recommendations that come from the women themselves. So it's not something that WHISE kind of made up or thought of. All of it comes from the focus groups, the survey responses that were pulled together for these recommendations. And I think that shows in the power and strength of what you've seen today. We're now going to take a 5-minute break. Just to give yourself a breather. There's a lot to take in there. A reminder also of those support services, and important to look after yourself. Grab a cup of tea or a glass of water, and we'll see you back in 5 minutes, which will be 10:45. We'll see you soon. Thank you. Okay, we're going to start in about 1 more minute. Welcome back, everyone. I hope you have had a little stretch or refresh or a cup of tea. Now we're going to get into a wonderful conversation with our wonderful panelists today. I will find their that's when we need to, there's so much to their bios. I've got to make sure I've got the right things to read out. All right. Welcome back, everyone, to the launch of My Body, My Voice report. We've heard from Natalie and Rachel in regards to some of the very powerful process and why this report is so important. We've gone through the methods and some of the findings and key recommendations. And now we're really excited to have 3 wonderful panelists to talk a bit more about the issue, both from a practitioner but also lived experience perspective. I'd like to introduce Jessica Hooper. Jessica is a lived experience advocate. Her pronouns are she and her, and she is a lived experience disability advocate living with a neurological disorder since 2019. Jessie has experienced firsthand the world from 2 different lenses and has worked hard to advocate for people with a disability in multiple formats. In her 24 years, Jessie expresses her life as living multiple different lives, having been a nurse before her acquired brain injury and now needing the assistance herself. She's battled mental health and body health issues, however, keeps a smile on her face and her carers on their feet. Welcome, Jessie. I'd also like to introduce Josephine Money. She's the clinical director of Eat, Love, Live. Jo is a dietitian and credentialed eating disorder clinician, passionate about eating disorders, body image, body diversity, and weight neutral care. Jo is the founder of Eat, Love, Live and co-founder of Eat, Love, Live Foundation. Welcome, Jo. Also welcoming back Natalie into our panel today. Nat is the Women's Health and Engagement Officer at WHISE, and she has a background in dietetics and lived experience of body dysmorphic disorder. She's extremely passionate about mental wellbeing, body image, and advocating for underrepresented groups. And she is the leader of this program, and along with Rachel and Charlotte. So welcome, everyone. Feel free to take yourselves off mute. And I just want to say thank you to those participants that sent in questions. We're going to try and get to as many of the questions as we can within this conversation, but we'll see how we go for time. The first question I have for the panel is, can you share your own knowledge or experiences with body image and disability, whether it's in your own life or your practice? And I'm going to get Jo to start with that question, please.
Thank you so much, Chrissy, and thank you so much to WHISE for inviting me to be part of this. It's a really amazing document. I think this is a really pivotal document where some pretty amazing stuff has been documented, things that we as practitioners have heard from our clients, but as we know, having these things written down and really capturing that lived experience is so important. This is a really important topic, and I'd like to acknowledge that I'm a human. So yes, I have my own body image stuff, as we all do, but I don't think that's helpful for today. What I would actually like to do is acknowledge the privilege that I have of so many women and clients who have come to me and are willing to be open and vulnerable and share their experiences of living in their own bodies. And I'd like to kind of acknowledge my own privileges and the platform that gives me to be able to share some of their responses. What I've heard in my practice, so I'm a dietitian. I have worked pretty much exclusively in eating disorders my whole career. And so talking about bodies and body images and how people feel about their body has been pretty much everyday work for me, which is lucky because I think it's a really important conversation that people don't often have a space for. The reality is the way our body shows up in the world is often the first thing people see about us. We would like to live in a culture where it's not important. We'd like to just, as one of my lovely clients refers to it as her meat sack, she'd like it just to be the meat sack or the holder of her soul and it not to be seen and judged. But we live in a culture where there is this layers of layers and layers and layers of systems which have created expectation, and particularly when we're talking about women, of how they're meant to present. I really was fascinated by, within the report, and as Rachel spoke to today, when the lived experience quote was talking about how this particular participant felt like they needed to really perform femininity over the top because of their body and the way it presented and their disability. They felt like they need to make up for that in some way. And I think this is an experience that happens all the time. We know from our own experiences, we know from the research, we know from the clients we've seen that people are judged on their bodies. I do a lot of advocacy in the fat liberation space. And so one of the things that I'm really passionate about and spend a lot of time talking to people about is body size. And we know that the bias around body size means that stereotypes are applied, assumptions are made, and people are mistreated, ignored, not believed. Their harm is often compounded repeatedly within the care system and the medical system with health practitioners, which is devastating, really, because often we come, it takes so much courage and vulnerability to turn up to a health appointment of any sort, particularly when there is multiple intersections of identities, disability, things going on, physical and mental, and then to have a practitioner who doesn't see you, doesn't listen to you, doesn't value you, often leads to this, well, we would perhaps talk about medical trauma and then people avoiding these spaces. I mean, that's just one aspect of where body image can really, well, not even body image, I guess we're talking, what I'm really alluding to is the systemic bias around bodies, particularly perhaps body size, that then is impacting people's body image and contributing to medical stigma and avoidance of healthcare. And we can imagine the outcomes of avoidance of healthcare. Now I could go forever, but I'm going to pass over to someone else because I'm curious to hear other people's reflections.
Yeah, thank you, Jo. And I think that's really important to acknowledge that the medical bias and discrimination that women with disabilities face. And in the report, it shows some examples of women with disabilities just stopping seeking care altogether, which can be really life-threatening and dangerous. Thank you so much for your reflections. I'd like to move to Jessie now. Can you tell us a bit about your experience with body image and disability and what about this report that interests you?
I just want to say well done to everyone for this report. I'm really proud of everyone and what they've done. So my experiences with body image kind of come twofold. I have a brain injury. So for me, I have body image issues that I don't look like anyone kind of around me. My limbs are all folded in. My hands are folded and curved. My feet are folded and curved. I get stopped on the street to go, oh, I saw your legs over there and they don't look right, or why aren't you wearing shoes? And I can't say, oh, my feet are too swollen and I can't physically wear shoes anymore. My spine is all curved because I can't hold myself up properly anymore. And trying to actually cope with that, and the fact I get stopped on the street, I get clinicians telling me that I'm overweight, I get my parents telling me I need to lose weight when I've actually been diagnosed with anorexia multiple times, but because I physically look overweight, that and I have no ability to actually move, but it's the physical look of me that looks overweight. And it's really difficult that people don't understand what is actually going on inside. So I've been diagnosed with anorexia multiple times. And then it's also quite interesting because I've got quite high level of autism, which we realized that I have actually got ARFID, which not many people know of. ARFID is an eating disorder that often goes with autism, and it's a sensory type of eating disorder, and it is a food restriction because of the sensory intake. And it's been quite interesting that going through my high school years when I didn't have the brain injury, and I would get physically food shoved down my throat and things like that, shoved down my throat when I was anorexic and put into the hospital and things, because I could not physically eat. I could not get that sensory down. But people didn't understand that. The clinicians didn't understand this, and getting told that, you just don't want to eat, you don't want to get the food, you don't want to do anything to help yourself, but there's that complete lack of understanding that it isn't that. I do want to eat, I do want to do it, but there is that body image as well that kind of goes with it. And even so, I've been taking notes throughout the presentation that I even now I want to wear dresses, and I can't because I sit down permanently and it makes me look like I'm pregnant. And I just want to wear the dresses and I want to feel pretty and feel like that. But I can't because I'll go out and they go, "Oh, are you pregnant? Are you expecting?" I went, "Thanks, I can't actually get pregnant and you've made me feel really crap about myself." So yeah, asking my physio to change parts of me, to put me in splints so that my body stops getting curved, so I stop getting the comments. So it's this constant cycle of wanting to change me, but physical features of me wanting to eat, but I can't eat. So it's a constant cycle of everything.
Yeah, thank you, Jessie, so much for sharing that constant cycle. And it struck me that you've talked about so many different people feeling like they can tell you what they feel, from people in public to parents to family, people on the street to medical practitioners having judgment on your body and how that's affected you. So that's thank you for sharing. Natalie, I'd like to go to you. What can you tell us a bit about your experiences or knowledge in this area?
I firstly want to acknowledge Jessie's courage in speaking about all of that. It's not easy speaking about lived experience, and I wasn't entirely sure how much I was going to speak about today, but Jessie gives me so much courage. So I probably bring a different perspective to Jessie, because Jessie's discussing, visible disability and the discrimination and stigma and horrific comments that incites. But, my experience was that of invisible disability. So that actually incited something completely different, which was that I lost a huge amount of weight to appear as malnourished as possible so that I could gain some care from healthcare professionals so that my disability could be taken seriously. And it became more and more apparent to me that the thinner I looked, the frailer I looked, the sicker I looked, the less I could walk, the more out of breath I appeared, the more care I was receiving, and the more blood tests and scans they were willing to do. Whereas if I looked in a normal sized body, or a straight sized body, I should say, then I was just met with ableism time and time again, which is, you look pretty healthy to me. I don't see a cause to investigate. So, so for me, it was kind of the opposite, where the ableism of healthcare practitioners is kind of what incited negative body image, to the point where I disliked the fact that I didn't look sick enough for their care. So yeah, a very different experience to Jessie, but one of invisible illness, which I think is really interesting. And I think along those same lines, I began to feel a lot of body hatred and a lot of self-loathing towards my body, for, quote unquote, failing me because it couldn't do the things that it was doing before. And then that horrifically impacted my body image, because then my body became even more of a project than it did before. And every ounce of my thoughts and behaviors were spent on trying to fix my illness and disability in a way that had never consumed me in the past. And so that meant trying to fix it in any way possible, whether that be alternative medicine and naturopaths and the rest of it, and strange diets and supplements and medications and whatever it might be, throwing heaps of money in different directions to try to make my body fit the functional ideals that Rach was talking about before, in order to regain my life back. Meant that I ended up, with a horrific eating disorder again. So, yeah, I think it's really interesting the way disability, body image, and eating disorders intersect, because that focus on the body is there. So that's my experience.
Thank you so much for your courage and vulnerability, Nat, and sharing your story as well. And I've heard both from Jessie and Nat the word cycle, a cycle that can continue, and that the ableist notions and structures that aren't supporting you in the way that you need. I'd like to bring another person's lived experience into this, who's one of the people who've joined the webinar, signed up for the webinar today. This is one of the questions from one of our participants. And it says, I'm peg fed, which is a feeding tube, as a result of my physical disability. I developed anorexia nervosa as a result of my struggles and food and body, but I'm unable to access psychiatric inpatient care with my peg, with my feeding tube. How can we make inpatient eating disorder care more inclusive of people with differently nourished bodies when the excuses for refusing care include patient complexity and safety and risks? How is it possible to walk away from experiences of exclusion like this and not conclude that my body and I are the problem, rather than the inflexible system of care? Jo, I'd like to pass this to you, if that's okay.
Absolutely, thank you. I'd like to acknowledge Jessie and Nat and the person who's asked this question for their, I think courage is the word that's been used a lot, but actually sharing so beautifully and articulately the real distress and the real barriers that people are facing. I don't think I need to tell anyone here that our healthcare system's a bit broken, particularly our mental health care system. There has been an injection into eating disorder spaces, from primary care right through to prevention in the last few years, but it's going to take a long time for those changes and strategies and things to come into place. And what this person is describing is something I hear all the time. The tertiary centres of for eating disorders care, particularly in the public spaces that are designed for people that need inpatient support, are not always well equipped, able or willing to support people that fit outside a mould. I can't
Yeah.
comment exactly on this person's experience. I can acknowledge that it's shit, and I'm really sorry it's happening to you. Sorry for swearing. And it's not okay. You know, often in these situations, there's lots of advocacy that takes place, all sorts of things, because there is so many people involved in these organisations. And I'm just wondering the most helpful way of addressing this. My little brain's going on thinking about, you know, if we're thinking about, actually, I'm going to step back a little bit. I think one of the things that this really highlights is, you know, speaking as a health practitioner, many of the recommendations in this paper, I mean, really, it should be presented to all students in any sort of allied or medical health.
Yeah.
And these sorts of lived experience, qualitative data needs to be the basis of our training, because one of the places where there is a lack of client-centered individual understanding is the way that, you know, I can only talk to how I was taught, but my impression of the way that we're taught as health practitioners to see individuals in an illness.
Yeah.
And there is a lack of awareness of the social determinants of health. There is a lack of awareness of intersectionality, identities, trauma, and those sorts of things. And so what we're actually seeing is this perpetuated through the system. And so if we kind of take that, what we're learning at university is often very individualistic and blamey, for want of a better word. I can't think of the right academic word right now. But there is not a welcoming of thinking about the client holistically. I think health practitioners are health practitioners because they desperately want to help people. And then we go and learn a particular way of doing things. And then we go into a system that is often underfunded, you know, under-resourced. There's not enough time, which then leads to, you know, clinician burnout and not enough energy. And there is absolutely people that can then reflect on their learning and find ways of being more client-centered and individualistic, and flexible, and still working in the evidence base, and, you know, taking the time to genuinely listen to clients, to validate, to think about how they can meet their needs. And that in itself can be a privilege. You know, I acknowledge I work in the private system at the moment, and so I have time. And that's not always there. So the reason I was bringing that up is I think what we're seeing is when we get to sort of inpatient eating disorder treatments is long-term, some of those things that have been in a system that needs overhauling. And that takes time and money and energy. And if anyone is in public health trying to make changes, there's a lot of things to jump through. So that's just some thoughts. I don't want to in any way excuse the harm that these systems create, because the reality is, yes, this is speaking to an individual and saying, you're too much, you're too hard, we can't manage that complexity, and that's not okay, because everybody deserves help, and whatever that help is. And I can only hope that this individual is able to access some supports to help them advocate and access an inpatient support where their needs can be met and there can be some flexibility to support them in containing the eating disorder and being nourished in the way that they need.
Absolutely, Jo. Thank you so much. And I think, as our CEO of WHISE often says, Kit McMahon, you can hear us, it's not about fixing the women. It's about fixing the systems and structures. So absolutely. Jessie, I'd love to go to you to respond to that question or continue this conversation, please.
Yeah, this one, you know, it really touches me because I've been in this situation quite a few times. I am told I'm complicated or complex at least once a week. I've been denied from medical systems for being too complex, for being too complicated. Doctors telling me I'm too complicated because I have multiple disabilities or medical conditions going on. So this really, yeah, it's a constant. I've been admitted to psychiatric hospitals or psych wards where they've taken my wheelchair off me and I'm, you know, having to pull myself on the ground because it's a risk. The wheelchair is classified as a risk I'm classified as a risk just being there. I won't get a wash, I won't get any help. I'm either stuck on my bed or there's no call bells in a psych ward. So, you know, I'm crawling and pulling myself on the floor so that I can go get some help. And that includes you don't get food trays brought to you. And so if you're in there to try and get help with eating, it just makes it worse. And I've been in there so that I can get help with eating. At one point, I hadn't eaten for a month and I got a tube down my nose and I got taken off the psych ward to a general ward so that I could get the tube down my nose and get force-fed food. But because I was needing that nutrition, I was required to be off that psych ward. I did not get any psychiatric help. I could not get any of that help that I actually needed. If anything, you know, if I needed any psych help, they had to request it through the general ward to then go to this registrar's, who then went to this other ward, who then got to the psych ward. And by that time, I was majorly messed up. So, and it just made the stay longer and it made me more and more upset and depressed. And that has happened multiple times. And it's hard because you were told you're complex, you were told that you are not able to be there. And, you know, I've done quite a bit of advocacy on this. I've contacted the Premier, I've contacted, you know, people who should be doing something about this. And I've actually been told that there is an actual divide between medical and mental. And I remember going through this with Natalie in the focus group saying that when I was training as a nurse, that, you know, I did my mental health placement and I did my general placement. As soon as I went on to my general placement, we were told to forget everything from our mental health. We were there for general health. And that really struck with me that you are not there, and that was the same with mental health. You were there for mental health. You're not there for anything for general health. And that's really a shame because you need to be there for both. If you're, even without the all the complexities, any chronic illness, anything, everyone who is in a hospital bed is going to be feeling some type of feeling that nurses, doctors, anything need to be able to equip themselves with some type of mental health training. And it's really upsetting that, you know, as a nurse, we were told you need to separate yourself from the medical and the mental. And it's really demonstrated within our system that that's exactly what's happening. And being a patient within that system as well, it was even more shown that that's what happens.
Yeah, wow, that's awful that you've experienced that. And Jessie, you know, your insights in coming from both sides as a nurse yourself and now someone who needs care adds that, you know, extra layer of understanding, but I imagine also frustration and the importance of, you know, holistic care that meets the needs and trauma-informed care. Because from what I'm hearing from you and Nat and the person who wrote these questions, are often the feeling is that patients feel like they're that complex problem that needs to be fixed versus let's adapt the system to meet the needs. Thank you so much for sharing, Jessie. I'd like to move towards, I guess, thinking about what we can do. What are some of the solutions? We know there is so many recommendations that have fallen out of this report, but I'd love to hear from the panel. What do you think, or what needs to change in the healthcare system for women with disabilities to gain the support that they need? What needs to change with the healthcare system to address these gaps? Jessie, while we've got you there, do you want to continue what you feel?
I think honestly, the entire healthcare system needs a big override. You know, you can see the AMBOs, the nurses, everyone's, you know, I'm going to say fighting because my brain can't think of a better word right now. Everyone's trying to get, you know, better work, better wages, and for that everyone's kind of suffering at the same time as well. So in that saying, the whole healthcare system really needs a whole overhaul to start at the universities, at the training centres, and it needs to keep going throughout the hospitals, and the doctors' clinics, the dentists, that pretty much everywhere. Anywhere that is providing any type of medical care, any type of care, pretty much coming from carers, coming from dentists, nutritionists, anyone. It really needs everyone to kind of band together and say what they're doing at the moment isn't working for people with disabilities, and especially women. Women have the highest amount of we've got a really significant amount of eating disorders, and people with disabilities are not represented often in those numbers. And so it's really good that we've got this, we've done this because we need to be able to show that women with disabilities are extremely affected, and it is the healthcare system that's kind of, helping input this as well. It's what they're saying, it's what they're doing. And then it's going, a lot of people are listening to the healthcare system.
Yeah.
So it's what they're doing that then's going to be going into the general public and going, oh, what I've just said is really ableist, what I've said isn't right. So it's dependent on the universities and the healthcare system that they need to be changing what they're doing and what they're saying, that, listening to people with disabilities, changing what they're saying, recognizing that each person is very different, what they're able to do, what they're eating, what's going on, and be able to recognize that we shouldn't have people starving themselves to get medical attention. We shouldn't be all sorts of things. Like it's not right. We need to be able to have people be themselves and get the help that they require without getting any stigma or ableism or any of that.
Yeah, absolutely. The whole system, from allied health through universities, the whole system needs to change. I'm hearing you loud and clear.
Even teachers.
Teachers. Yeah. Natalie, what about you? Is there anything specific we know? It sounds like, Josie, you're passionate about the whole system, and that's, seems reflective of our recommendations. What would you say?
Something that's really been poignant for me just in listening to this conversation about the previous question and, Jessie's story is, for me, it seems that lived experience health practitioners don't exist as much as they should. And I think it's the really sad reality is that Jessie is no longer a nurse. That shouldn't be the case. If ableism didn't exist, she could still be a nurse and she could be one of those people changing the healthcare system. So, I think the biggest issue is that women with disabilities are no longer in our employment of choice. We're no longer in the healthcare system. And so the ones who have the best knowledge on how to change it, who can see people as holistic people and who can see the red tape on inpatient treatment, who were the best to acknowledge, hey, this person's neurodiverse, let's do this, and this, not give them these rigid structures on how to eat in the eating disorder unit. Hey, this person may be in a slightly larger body and not have a BMI of 16.5, but they still have anorexia, they can absolutely come in. It's them that still need to be their healthcare professionals. So, I think the biggest issue is that as soon as we become ill or unwell or something happens, we can no longer upkeep with our accreditations, or we're no longer, our ways of thinking is slightly different. And so we're no longer fitting in or belonging in the healthcare system, which is the biggest issue. So I think Rachel's point and her recommendation around a lived experience workforce is probably one of the best ones.
Yeah, that's such a great point.
That's a lovely
Nat?
reflection. Is it okay if I build on that, Nat?
Yes, please.
Go for it.
I think that so powerful and so true. We need this lived experience voice to be upheld at all levels of the healthcare system. And it's improving. Like, we're having the conversation, there's more of this, but it's nowhere near enough. And to your bigger question, Chrissy, I think there's so many recommendations and so many things we could do. But I'd like to build on Nat's reflection, because I think as health practitioners, it has not been a safe space to be authentic and genuine.
Yeah.
We are not taught, and again, I'm making generalist responses, but generally we're not taught relational skills. We're not taught the soft skills well enough. We're not taught how to care for ourselves. And so traditionally in these spaces, we're told to be robots. You're meant to leave yourself at the door and not have a human response. And so it hasn't been safe for people to share their own lived experience as health practitioners. It's been, there's ableist structures that mean people can't continue, as you've talked about, in their chosen profession or training. As someone who's been looking at this for much longer, perhaps than Nat and Jess, what I would like to offer is some hope. I've noticed in definitely the eating disorder land, which is where I sit, in body image and eating disorders, there is so much more safety now in people being able to share lived experience and be regarded highly as a professional. People are feeling more able, because of the courage of a few, to share their identities, to share their disabilities, and to openly put that there. And I can only again speak from a private perspective in terms of healthcare, but consumers are requesting that. People come to us seeking a dietitian or a health practitioner that shares their identity or has lived experience of their disability. And I think that that is a really powerful and hopeful thing, that there is some consumers that are feeling empowered to seek care that fits theirs. Obviously, there's a whole accessibility issue with that, particularly from a resources point of view. But also there is, a slight movement towards practitioners feeling safer and more supported to be honest and open and bring their whole authentic selves, including their own disabilities or experiences to that.
Would you say that's also true in a hospital setting?
Oh, shit, no.
The public, no, yeah.
Look, I think that there's definitely pockets, because I think it's about the individual who's perhaps in a management role. And if they, them being able to support someone. And I think there is amazing individuals in the healthcare system, in the public healthcare system. And it's about bringing them together to support each other so they don't get burnt out before they can make significant change. And so, like I said, I completely acknowledge my view and experience being from one particular area, but it's just nice that these conversations can happen now. Health practitioners are feeling a little bit safer, and hopefully that's something we can foster more.
Yeah, that message of hope is really important, isn't it? All the stories we're hearing and a lot of the evidence that we hear from this study can be really confronting and depressing. So I think that importance of really, what are the strengths here? It sounds like there is some good practice happening. So how can we build upon those good practices? So on that, I might ask Jessie to answer this next question, but maybe each of you on the panel. What's one piece of advice you would like service providers or healthcare providers to know? What would it be? What would be the one piece of advice you'd like service providers or health providers to know to improve their practice and systems? Jessie?
When I always get asked this, I always say, I'm a person. A lot of people forget that I'm actually a person. They always see me for, all the illnesses and the disability and all that. But I'm a person first. What they're saying, what they're doing, it hurts. And then they look at the chronic illness, and then look at that. Yes, things can tie up together, but they're not always necessarily together. My eating disorders, only one part of it is combined to the autism. It's not connected to the brain injury. It's not connected to everything else. You know, some parts need to be forgotten about the rest of the disability. But please remember, I'm a person first, not everything else first. When I go do talks, I always ask them, what do you see about me first? And they always say the wheelchair or my disability. But I'm the person first. And that's what I really liked about the recommendation. It's patient-centered care. It's person-centered. And there's something that a lot of practitioners and a lot of people forget is that I'm a person. I'm not, you know, someone just sitting on a chair. I can talk to you, I can respond to you, I can tell you how I'm feeling, and I will tell you loudly what's going on. But I'm a person, so please treat me like a person and, you know, respond to me.
Thank you, Jessie. That, you know, it's such a simple message that you think would be easy to grasp, but clearly it's not your experience. But I'm a person. I also just wanted to say thank you to those who've been commenting today.
Yeah.
I've got Ruth, who said, as someone who participated in the focus group, I want the panel to know that I'm grateful for your work and your vision. Thank you for seeing us and for having the courage to not look away. And I think that comes to what Jessie was saying about, you know, we are people, we are people. And Star Victoria, someone saying, yes, I'm someone who developed a disability with my feet. During the treatment phase, I was not allowed to continue working as a disability support worker on restricted duties until I could walk again. I had to leave my job and find another to be able to survive. There's no support to keep me in my job. And that goes to the points you're making about that lived experience being, and hopefully we're now seeing shifts in this, but it's clearly we've got a long way to go for people with lived experience able to continue to work in the healthcare system. And there's lots of other comments there. Thank you, and keep them coming. We are getting close to time, so I'm going to ask Nat to answer that question as well. What's that one piece of advice you'd like service providers or healthcare providers to know?
I would like them all to go on their own internal journey to discover their unconscious biases on everything, gender, on ableism, sexism, misogyny, racism. Just go on an inward journey, and the further you get in that inward journey, the better the practitioner you will be.
I love that. Love that. That inward journey to discover your unconscious biases to try and get rid of them altogether. Love it.
That's my one piece of advice.
Thank you, Nat. And Jo, what's your one piece of advice?
One piece. I think I'd like to remind health practitioners that the expert is sitting in front of you. As health practitioners, we are not the expert of individuals. The expert of every individual body lives within that body. And so we need to, you know, really sit down and shut up and listen and really value and trust what we're hearing from the individual themselves. They can tell us what's going on. They can tell us what they need and what's going to help. It's up to us to sit beside them and listen and facilitate in whatever way we can.
I love that. Oh, how poignant. So we've got the 3 key pieces of advice coming from Jessie. I'm a person. Treat me as an individual, not as my disability. From Nat, go on an inner journey to question your unconscious biases. And from Jo, that the expert is sitting right in front of you. It's the person that you're treating or having conversations with as a person. So I think there's some really good pieces of advice, and I know you have so many more. I wish we could keep talking. An hour and a half had just flown. Thank you to all of those who have made it here today, and to those who will hopefully be watching this webinar later on. A huge thank you to our panel, Jessie, Nat, Jo. A big thanks to Dr. Rachel Bush, and to everyone who input to this report. Thank you so much for your courage and your vulnerability. Remember to look after yourself, Here is the report again, if you haven't already downloaded, but you can always go onto the Women's Health Services, the WHISE website. We would love to get your feedback on this webinar, what you learned, what you'd like to see more of. This is just the beginning. This report is just the beginning. WHISE is going to be looking to work and look into trying to change, adapt the systems to take on these recommendations and to enable healthcare providers and prevention practitioners to change this work, to enable women with disabilities to have more equality, to have humanity, as was mentioned earlier, in regards to the practice. We'd love to hear your advice. So please have a moment to fill in this survey. And again, thank you so much. Look after yourselves. It might have triggered some emotions within you. The support services are available. Again, the butterfly.org organisation, the National Helpline, Lifeline and Eating Disorders Victoria. Feel free to reach out to us and I hope you have a wonderful afternoon. Thank you so much.
Thank you.